about Checkmate 901 trial.
Before that, just in the amplitude trial also about doing this testing, and because in our settings in the lower middle income group of countries, the testing also very expensive and the drugs also very expensive.
Yes, sir.
So in that case, I thought, as you said, that in metastatic highly selective area, even the age also, less age, less than 65, maybe we may select, and only BRCA we may do that compared to the other HRR panel, no, isn't it? I think
Even sir, treating the patient, clinical scenario may be a big factor.
Yeah.
Aggressive clinical scenario may not
that also,
suited
yeah.
for the oral treatment.
Yes, but all tests we are not doing, even in the lung when we are ordering for the testing for TKIs. First we do the EGFR. If it is negative only, we go for the ALK and ROS1 and all, because to avoid the costing rather than at once do all the tests, because those are very costly and our patients are not affordable to do that. With that one point, and then for the 901, as the presenter exactly told about this enfortumab and Pembro, it is a very big change has occurred. Sometimes you may go for that, but still those are very expensive, and the matters are related to the immunotherapy related side effects, and those things matters, and that he has mentioned it. But later on we may be doing FGFR mutations and going for sacituzumab govitecan, that sort of study treatment also. But other than that, overall, I thought about when to select and whom to offer these things, because in ASCO, best of ASCO, when we select and present here, we may not be able to practice it in our settings. That's only one other thing. Even for the last study about this Pembro adjuvant basis also, in our settings we are not practicing. We usually follow up till we get those things, but these are really speaking very highly risk patients like sarcomatoid and lymph node positive patients. We may include it, but everything in our settings, the financial toxicity and the tailored use of these studies is actually in practical manner only we have to practice this game changing. Unless it is a real game changer, we may have to go for that. With that comment, I'll hand out.
Thank you, sir. You have practically mentioned the FGFR mutation and the option of enfortumab vedotin and other things. But despite that, in the patient having the cisplatin toxicity, it's an option for having option for treating the patient with renal impairment or hearing loss. So lastly, I want to ask Professor M.A. Salam sir to say something in conclusion with the trial of Keynote 564.
I think 564 seems to be a very interesting as well as very logical studies, because we have seen in our clinical practice, say a patient goes for a partial nephrectomy, he has got a margin free, all the margins are free,
Yes, sir.
but he has got a sarcomatoid change. This patient may be followed up without any treatment because his margin is free, but I am sure that he will be having some kind of recurrences in course of time if he is followed up carefully. But as a routine, if the pembrolizumab is given as a single therapy, as the study is saying, I think that has got a lot of logic. Why this has got logic? Because one of my patients, last week I have seen, he had radical nephrectomy for a about 10 centimeter renal mass. He had to, we tried for the partial nephrectomy, but he was not, he was not a candidate for
Yes.
partial nephrectomy. Nephrectomy was performed. About 9 years back, this patient was followed up very carefully for 2 years. Then he lost follow-up. Now in the last week, he presented to us with a profuse hematuria. And on investigation, on a CT scan, his renal function is still good. On a CT scan, we found that he has got a big tumor on the other side and recurrence of the tumor on the side where we operated, on the left side. So recurrence of the kidney tumor as well as recurrence of the, or reappearance of a new tumor in the other side. That happened without his knowledge. He is completely asymptomatic and he is unable to bear any kind of drug like pembrolizumab or anything. That is one of the reasons, that is a different reason. But truth is that this is possible. We should be very careful about the high grade, high risk and lymphovascular invasion as well as the sarcomatoid change or any abnormal change like small cell cancer or something like that. They should have some adjuvant treatment, maybe with pembrolizumab. I appreciate the presentation was very good. Thank you very much.
Thank you, sir. This concludes the urogenital session for Best of ASCO. I would like to ask our chairman and our main person of Medical Oncology Society in Bangladesh, Professor Parveen Shahida Madam, to come to the dais and conclude the session and give the memento to the panelists and the speakers.
Thank you, Dr. S.M. Ariful Islam. It's time to encourage the speakers by awarding them a token of appreciation. I would like to request Professor Dr. Parveen Shahida Akhtar, President, Medical Oncology Society in Bangladesh, to come up on stage and present crest to the speakers of this session. I request the speakers, panel of experts, and moderator of this session to remain on a stage for a group photo.
First, I request Dr. Arun Shahi to kindly receive your memento.
Now I request Dr. Abdullah Al Mamun Khan to kindly receive your crest.
Next, I request Dr. Omar Farooq to please receive your memento.
Now I request Dr. Mohammad Rafiqul Islam sir to please receive your memento.
Next, I request Professor Dr. M.A. Salam to kindly receive your memento.
Now I request Professor Brigadier General Mohammad Kudroti Ilahi to receive your crest.
Hello. At this point, I kindly request Dr. N. Jayakumaran to please receive your memento.
Now I request Professor Dr. Mohammad S. U. Chaudhuri to please receive your crest.
And finally, I request rapporteur of this session, Dr. S.M. Ariful Islam, to please receive your memento. Thank you very much. Once again, I would like to request our respected audience to please complete the survey question and 2025 Best of ASCO Attendee Program evaluation form. Our volunteers will collect the forms from you. Our next session will resume shortly. Thank you for your presence.
Distinguished audience, it's time to commence our next session. This session is entitled as gynae oncology, head and neck cancer, and others. The moderator of this session is Dr. Narita Khurshid, medical oncologist and consultant, Evercare Hospital, Dhaka. I now request Dr. Narita Khurshid to conduct this session.
Assalamu alaikum and a very good afternoon. Welcome you all to the next session. This session will include discussion about gynecological malignancy, head neck cancer and dermatological malignancy. Now I would like to invite our honorable panel of experts to come up on the stage and adorn their seats. Firstly, I would like to invite Professor Dr. Rehana Parveen Madam, Senior Consultant Gynecology and Gynecological Oncology, Square Hospital, Dhaka. Next, I would like to invite Dr. Mohammad Mohiuddin, Radiation Oncologist, Assistant Professor, Dalhousie University, Department of Oncology, Horizon Health Network, St. John Regional Hospital, Canada. Next, I would like to invite Dr. Vijay Kumar Srinivasalu, Senior Consultant, Medical Oncology and Hematology, Sparsh Hospital, India, to come up on a stage and please take his seat. Next, I would like to invite Professor Dr. R.P. Baral, Senior Consultant and Chief Department of Oncology, Norvik International Hospital and OM Hospital, Research Center, Kathmandu, Nepal, the SARC representative for the Asia Pacific Geriatric Oncology Society. Thank you, our esteemed panel, for adorning our podium. Now I would like to welcome this session Dr. Muhammad Masudul Hassan Orup, Assistant Professor, Department of Radiation Oncology, National Institute of Cancer Research and Hospital, Dhaka. The topic of his presentation will be neoadjuvant and adjuvant pembrolizumab plus standard of care in resectable, locally advanced head and neck squamous cell carcinoma. It's a phase 3 trial, key 3689. Dr. Masudul Hassan Orup.
Thank you, Dr. Narita Khurshid, and I would like to give my thanks, gratitude to the organizing member of MOSB and my mentor, Professor Dr. Parveen Shahid Akhtar Madam, for allowing me to talk on a topic in this forum. So I am Dr. Mohammad Masudul Hassan Orup. Welcome you all to my presentation on perioperative pembrolizumab in head neck squamous cell carcinoma, keynote study 689. So I would like to start with the groundbreaking invention for which James P. Allison and Tasaku Honjo were given the Nobel Prize in the year 2018. And it was nothing but the invention of immune checkpoints. So this immune checkpoint inhibitor, immune checkpoints pathway that give the way to invent the immune checkpoint inhibitors that started to play a role in the area of cancer, and it opened up the door, it opened up the hope of the cancer patients a new era of cancer was started with the invention of these immune checkpoints. And one of the major drugs of these immune checkpoints are pembrolizumab, the PD-1 inhibitor, which releases the brakes on T cells, enhance the immunity, which attacks the cancer cells and cures it cures the cancer patients. A wide range of malignancies are now being treated with immune checkpoint inhibitors, and also it has got some application in the head neck cancers. So why the pembrolizumab is required in head neck cancer? Because you know that the standard of care in case of head neck cancer patients is the radiotherapy, chemotherapy, concurrent chemoradiotherapy. Already some of the applications of pembrolizumab is approved in head neck cancer patients, but those are all in metastatic settings. So why the pembrolizumab needs in head neck cancer patients? Actually, in metastatic cancer patients, earlier it was investigated, but then the investigators tried to explore its application in non-metastatic head neck cancer patients. So why do we need in pembrolizumab in non-metastatic head neck cancer patients? Because you know that head neck cancer patients, this is a global burden. And in Bangladesh, it is the second most common cancer. And the presentation of these head neck cancer are mostly in the 3rd and 4th stages, and it is up to 60 to 70%. That means that 60 to 70% are presented in a locally advanced stage. And the survival rate, if you see the survival rate, the prognosis is dismal. So in view of this, investigators started thinking of applying the checkpoint inhibitors in the neoadjuvant and adjuvant settings in head neck cancer. And Douglas Atkins from Washington University, St. Louis, who is a medical oncologist, and his team started exploring pembrolizumab in neoadjuvant and adjuvant settings. And it is the phase 3 trial, Keynote 689. So the study design of the experimental arm was neoadjuvant pembrolizumab followed by surgery, and then adjuvant pembrolizumab and the standard of care like concurrent chemoradiotherapy. And the key outcomes were significantly improved event-free survival, higher pathological response rates, prolonged distant metastasis-free survival, and manageable safety profile. So this is the study design of Keynote 689, and it is a global trial, randomized, double-blinded, placebo-controlled, and phase 3 trial. The sample size was 980 patients enrolled worldwide, and the place of studies was conducted approximately over 200 study sites worldwide, North America, Europe, Asia, and other regions. So what is the inclusion criteria? Adults with resectable locally advanced head neck squamous cell carcinoma patients. The subsets were larynx, hypopharynx, oral cavity. Stage 3 and 4A patients were included in this study. And oropharyngeal cancer patients, both HPV positive and negative, were enrolled in this group. Patients had very good ECOG performance status, non-metastatic, and tumor tissue was tested for PD-L1 test. So what is the study design? In arm A, the patient received 2 cycles of neoadjuvant pembrolizumab, followed by local treatment, that is surgery, and followed by pembrolizumab 3 cycles and concurrent chemoradiotherapy where needed. And also they received another 12 cycles of chemotherapy. That is, the patients, the arm A group received 17 cycles of pembrolizumab, 2 cycles before surgery and radiotherapy, and 15 cycles after surgery. That is 1 year of pembrolizumab. And the second arm, that is the SOC arm, that is the standard of care arm, who received surgery and then radiotherapy plus minus chemotherapy with cisplatin. The stratification factors were primary tumor site, tumor stage, and PD-L1 test. And the primary endpoint of this study was event-free survival per RECIST criteria. Key secondary endpoints were major pathological response, and other secondary endpoints were safety, and exploratory endpoints included locoregional failure rate, distant metastatic free survival, and second cancers. So here are the results of this keynote study 689. The event-free survival, if you look at the curve, the event-free survival is well ahead than SOC, that is the standard of care curve. And if you see here, the median survival with event-free survival was 51.8 months in case of pembrolizumab arm, and in comparison to SOC arm, which is only 30.4 months. And the hazard ratio is 0.73 with a good p-value, it is significant p-value. Now, the event-free survival was tested as per CPS scoring. CPS score more than or equal to 10, CPS score more than or equal to 1. If we see the arm, the more patients were benefited in this arm, that is CPS score having more than or equal to 10 population with a good and significant p-value, and the CPS score, patients having CPS score more than 1 also had a very good response and with a significant p-value. So, if event-free survival was observed good in case of both in the low CPS score arm and in the high CPS score arm. The pathological response, it is divided by two subheadings. One is the major pathological response, which is defined as less than or equal to 10% remaining tumor in the surgical specimen. And here you can see that the patients having CPS score 1 to 10 or more than 10, and also the patients who are negative for CPS scoring also had response to the pembrolizumab. And all the three arms are showing significant p-value. So distant metastasis-free survival, here you can see again the pembrolizumab arm is showing a very good benefit of 51.8 months, and in comparison to SOC group, which is 35.1. So time of locoregional failure, here you can see up to 36 months, the locoregional failure rate is more or less same in these two arms. But after the 36 months, there is a clear difference between the SOC group and pembrolizumab group, and the patients having pembrolizumab was a more better locoregional failure rate survival. Some of the patients in this study had second malignancies. You can see it here, some of the second malignancies that the patient had at the time of study. So the safety profile, the toxicity profile, here as you know, the toxicity of pembrolizumab, which is added to this arm, here the any grade toxicities, grade 3 toxicities, some serious toxicities, toxicities that led to discontinuation of the treatment, led to death, and grade 3 immune-related toxicities, all are more in this group, pembrolizumab plus SOC group. So the positive aspects of this study is significant improvement of event-free survival, major pathological response, and potential new standard of care. So what are the key criticism of this study? First, it is unclear role of neoadjuvant or adjuvant immunotherapy. Cost and accessibility, you know the cost of the pembrolizumab, and the immature data of the survival data. You know that overall survival is usually the primary endpoint, but in this study, the overall survival was not the primary endpoint, and the survival rate, it is yet to come, the data is yet to mature in this study. The toxicity and adverse event, it is more in case of pembrolizumab arm, and in some subgroup analysis, there was a discrepancy between the outcome, because there are some of the sub-arms, there was a small sample size, and also long-term follow-up is needed for to say that pembrolizumab has overall survival. So what is the impact of Keynote 689 study? The impact is on June 18, 2025, the FDA has approved pembrolizumab for both neoadjuvant and adjuvant resectable locally advanced head neck squamous cell carcinoma. So these are the summaries. I'm not going through these because I have told already all these things. And thank you for your patience hearing.
Thank you, Dr. Arup. Now, I would like to invite our second speaker, Dr. Asma Siddiqa, Associate Professor, Department of Radiation Oncology, National Institute of Cancer Research and Hospital, Dhaka. Her topic of presentation will be pembrolizumab with concurrent chemoradiotherapy in participants with high-risk locally advanced cervical cancer, a descriptive analysis of final survival from phase 3 randomized double-blind trial in GOT. Dr. Asma Siddiqa.
আমি শেষ করি। Distinguished guests, respected teachers and learned audience, Assalamu alaikum. I am Dr. Asma Siddiqa. I am a radiation oncologist who worked at National Institute of Cancer Research and Hospital, Mohakali, Dhaka. I am grateful to the organizer for giving me this opportunity to present this trial result. For last 25 years, standard treatment option for locally advanced cervical cancer is chemoradiotherapy followed by brachytherapy. But the outcome is not up to the mark. 5 years survival is only less than 60%, so need some changes to improve survival. Many trials are ongoing. Keynote A18 is one of them. It is a phase 3 randomized double-blind trial, and descriptive analysis of the final survival was presented at ASCO 2025. Major takeaways from the study was pembrolizumab plus chemoradiotherapy followed by pembrolizumab maintenance improves overall survival and progression-free survival in locally advanced cervical cancer compared to standard treatment options with manageable safety profile. Background of the study came from some important landmark trials, that is the standard therapy for locally advanced cervical cancer is chemoradiotherapy followed by brachytherapy, and modern radiotherapy techniques, that is the IMRT or BMAT, has increased local control and overall survival with reduced toxicity in locally advanced cervical cancer. Most important parameter is important study that influences the author to doing this study, that PD-L1 inhibitor, that is pembrolizumab as a monotherapy or in combination with standard chemotherapy, has shown efficacy with manageable safety in recurrent or metastatic cervical cancer. Now come to the present study. This study included 1,060 patients, and all patients were from FIGO stage 2014, stage 1B to 2B, with node positive disease, and FIGO stage 3 to 4A, either node positive or node negative disease. They randomized the patients into two arms. One arm, standard chemoradiotherapy followed by pembrolizumab 200 mg 3 weekly for 5 cycles, followed by maintenance pembrolizumab 400 mg 6 weekly for 15 cycles. Another arm was conventional chemoradiotherapy with placebo followed by maintenance placebo. Primary endpoint of the study was progression-free survival, and secondary endpoint was overall survival. Participants were first recruited from June 2022 to December 2022. First interim analysis was done at 17.9 median follow-up result, and second interim analysis was done at 2024 January, and final analysis was done in January 2025. Among 160 patients from 176 centers in 30 countries are enrolled, and they are divided into pembro arm 529 patients and placebo arm 531 patients. Among the 529 patients in pembro arm, 5 patients remained on treatment, 293 completed treatment, and 230 discontinued treatment. And in pembro arm, no patient was on treatment. 280 patients completed treatment and 248 patients discontinued the treatment. Regarding the baseline characteristics, both the arm recruited similar characteristics patients. The PD-L1 positive patients were 94.9% in pembro arm, and in placebo arm it was 93.8%. Regarding the stage of the disease, most common stage was stage 3 and 4A. In pembro arm 56%, and in placebo arm it was for 57%. Regarding lymph node involvement, positive pelvic node was 60.2% in pembro arm and 61% in placebo arm. Radiotherapy, planned radiotherapy technique was most patients received radiotherapy in IMRT or BMED technique. That is in pembro arm it was 88.7% and in placebo arm it was 88.5%. Regarding the radiotherapy dose, more than 70 gray received. In pembro arm 91.9% and in placebo arm 91.3%. So summary of the radiation exposure, total number of the cycles of pembro or placebo received both arms 2020, cisplatin, weekly cisplatin received both arms 5/5 and overall treatment time was completed within 52 days in both arms. Regarding the radiation dose, total equated dose to D90 was 87 gray and in pembro and 87 gray in placebo arms. Regarding the brachytherapy, most of the patients received brachytherapy in 3D technique, that is 88.4% in pembro arm and 86.8% in placebo arm. Brachytherapy techniques were HDR brachytherapy and mostly intracavitary brachytherapy was given, that is 74% in pembro arm and 71% in placebo arm. Intracavitary and interstitial brachytherapy was used only 23.3% in pembro and 23.2% in placebo arms. Regarding the progression-free survival, there is a clear gap between these two curves. At 24 months, 67.8% in pembro arm and 57.3% in placebo arms. Progression-free survival at final analysis also showing the separation is going on between these two curves. Overall survival was same, that is the 36 months 82.6% pembro arm and 74.8% in placebo arms. Hazard ratio was 0.67. Overall survival at final analysis also similar. And these are these forest plot shows the subset analysis, and all subset analysis hazard ratio was less than 1, all favors the pembro arm. These are the events. Toxicity was similar in both arms, slightly raised in pembro arm. Summary and conclusion. So the author completed with a plain language that people with newly diagnosed high risk locally advanced cervical cancer who receive pembrolizumab and chemoradiotherapy live longer and without the cancer getting worse than those who receive chemoradiotherapy alone. Thank you.
Thank you, Dr. Asma Siddiqa. Now I'd like to invite our next speaker, Professor Dr. Shahana Parveen, Department of Gynae-Oncology, National Institute of Cancer Research and Hospital, Dhaka. Her topic of presentation will be Trial of Radical Upfront Surgical Therapy in Advanced Ovarian Cancer, the TRUST trial. Shahana Parveen, madam.
Assalamu alaikum. Good afternoon. Respected panelists, distinguished guests, dignitaries in the dais, dear audience. Thanks to organizing committee of the Medical Oncology Society of Bangladesh for giving me the opportunity for this prestigious program. The topic of my presentation is Trial of the Radical Upfront Surgical Therapy in Advanced Ovarian Cancer. The key takeaway of this trial, the patients with advanced ovarian cancer in TRUST had the excellent progression-free survival and the overall survival after maximum effort, that is cytoreductive surgery, and complete resection. Rates were high and morbidity and mortality were low. A statistically significant overall survival improvement for primary compared to interval cytoreductive surgery was not observed. TRUST is the first randomized phase 3 trial to show the improvement in median progression-free survival for primary compared to interval cytoreductive surgery without compromising the short or long-term quality of life. The background of this trial, TRUST was designed to settle the controversy about optimal treatment sequencing in advanced ovarian cancer under best practice condition where surgical excellence is guaranteed. The rationale of this trial, the rationale is to determine whether highly skilled upfront radical surgery can improve overall survival and clinical outcome compared to the more conservative approach of giving chemotherapy first in advanced ovarian malignancy. The quality assurance of this trial is that selection of the high experience center, only center with proven expertise, is performing radical cytoreductive surgery for advanced ovarian cancer were eligible. The surgeons, centers and the under the peer trial accredited their, that is their surgical credit and the auditors, the history of the patient, the audio and video of the surgery, everything should be in clear. The study design, it's an international multi-center, the randomized control phase 3 trial, which includes the FIGO stage 3B to up to 4B, epithelial, primary peritoneal and the ovarian malignancy and also the fallopian tube malignancy, histologically confirmed or cytologically confirmed disease eligible for both primary debulking surgery or neoadjuvant chemotherapy followed by interval debulking surgery. The primary debulking, the primary endpoint were the overall survival and the secondary endpoint were the progression-free survival, complete resection rate, surgical procedures, surgical morbidity and quality of the life. The endpoint and statistical designing, the overall survival to detect the survival benefits of primary debulking surgery over interval debulking surgery, and secondary endpoint was the surgical morbidity, quality of life and rate of the complete gross resection and time to start of the chemotherapy. The patient selection, the total 796 patients with FIGO stage 3B, 3C or 4A up to 4B, all the primary peritoneal, fallopian tube and the ovarian malignancy are included here, and the modified the intents to treat population 345 were included in the primary cytoreductive surgery group and 343 in the interval debulking group. The baseline characteristics of those patients, that is the trust baseline characteristics are the FIGO stage 3B to 4B, and the most common stage majority had the stage 3C, and in stage the histological confirmation group maximum are the high grade serous carcinoma. The surgical effort and the procedures, even though the upfront surgery arm had the longer operative time because of the higher rate of upper abdominal work, bowel resection, lymph node resection, they still achieved the higher rate of complete resection, that is 70% in that arm, and the interval surgery arm had the somewhat less extensive surgery, yet among those who didn't go for the interval debulking, the bowel resection or the extensive surgery. The surgical outcome, the patients in the upfront surgery arm underwent more extensive surgery compared to the interval surgery. This reflects the maximum surgical effort that despite that the higher surgical burden, the complete resection is more in the interval debulking arm because of the chemotherapy is reduces the tumor burden that causes the 85% in that cases. And the details on the systemic therapy, primary debulking surgery followed by the 6-cycle chemotherapy and bevacizumab is added, and in the around 15 milligram per kg body weight, and it will be maintenance up to 15 months. And in interval debulking group, after 3-cycle chemotherapy followed by interval debulking surgery followed by adjuvant chemotherapy and then bevacizumab, and in some patients PARP inhibitor was also included. The progression-free survival, the overall progression-free survival, the arm is in primary debulking arm it was 22 months, and subgroup analysis it was upfront surgery medial progressive surgery was 26 months versus 21 months, and the overall survival was in median in PCS arm it was 54 months, and in the interval debulking surgery group it was 48 months. And the treatment effects according to the subgroups, the subgroups treatment effect of the chemotherapy interval debulking surgery, which patients group got the most benefit and which ones shows the less. The subgroups shows the FIGO stage 3 have got a statistically significant progression-free survival. And the complete gross resection is also more in case of in that group. And the pre-specific exploratory subgroup analysis, this showed that the patients who achieved complete gross resection in upfront surgery arm had the substantially better progression-free survival compared with those who had it in interval surgery arm. The surgical morbidity, the cervical morbidity, it is found that in case of the any complication, the 18% in primary surgery arm and interval arm, it is 12%, and 30-day post-treatment mortality 0.9% versus 0.6%. And overall quality of life in both group are more or less the same. So in TRUST conclusion, while upfront radical surgery improves progression-free survival, the lack of statistical significant improvement in overall survival suggests that survival benefit is not conclusively powered for all patients. The strongest benefits are in patients for whom complete gross resection is feasible, and especially those with stage 3C disease. The key comparable trials and meta-analysis of some previous trial, that is EORTC trial, the CHORUS trial, the Scorpion trial, all these trials, there are more or less the progression-free survival and overall survival are in primary debulking group and interval debulking group are same. But what sets TRUST apart, that is gap, then that is remain. The TRUST trial specifically tries to address the surgical quality. It only includes center with high volume center where more than 50% complete resection rate in upfront surgery group. And early reports indicates that the TRUST showed a significant improvement in progression-free survival, and TRUST may better reflect outcome in setting with strong surgical infrastructure, which may change the risk-benefit balance compared to the older trials where surgical completeness was often suboptimal. So, the how TRUST differs or advocates beyond these trials. This helps to see why these earlier trials are related but not identical. TRUST is designed with very strict surgical quality criteria. TRUST includes a range of advanced stage disease, that is up to stage 4B disease, and earlier trials are often had lower R0 resection. So these are the criteria for who are for the primary debulking surgery and who are those for the interval debulking surgery. There is a disease burden more, there is a different area in those are the primary in interval debulking surgery. And this trial has answered the critical questions regarding surgical timing and outcome, but also opened new avenue for the investigations into patient selection and individualization of the treatment strategies, which future ENGOT and the AGO-led studies will aim to address. Thank you so much. Thank you for your patience hearing.
Thank you, Dr. Shahana Parveen, Madam. Next, our speaker will be Brigadier General Professor Mohammad Kudrahi Ilahi Sir, Professor of Medicine and Senior Consultant Medical Oncology, Asania Mission Cancer and General Hospital. His topic of presentation is Phase 3 trial of adjuvant cemiplimab versus placebo on high-risk cutaneous squamous cell carcinoma. Kudrahi Ilahi Sir.
Dear audience, Assalamu alaikum. I am honored to echo the voices of ASCO. That is most important. What I have seen in Chicago, now I am echoing those voices, we all. So it is a fantastic event for us. So problem is that our junior Dr. Kamrul, he has given us a big pillow to accommodate in a very short cover. Everybody is overshooting time. So p-value is significant. Let me finish my speech. That is, it is a phase 3 trial of adjuvant cemiplimab versus placebo for high-risk cutaneous squamous cell carcinoma. So, background is that we know cutaneous commercial carcinoma clinical management is surgical resection. It is 90% is the surgical management. And cutaneous commercial carcinoma are at high risk of disease recurrence after surgery and adjuvant therapy, and there are no adjuvant systemic therapy options proven as of today. So, but for recurrent and metastatic disease, this drug, that is cemiplimab, was used. But here we will talk about after surgery, there will be radiotherapy, then the cemiplimab, that is anti-PD for the adjuvant management. Here we see that surgery was done with high-risk features, followed by completion of post-operative radiotherapy, and cemiplimab, it is given 3 weekly for 12 weeks, followed by 6 weekly for another 36 weeks, and compared with placebo. And primary endpoint was disease-free survival. Now, regarding high-risk criteria, nodal disease and non-nodal risk factor criteria was taken. That is, nodal disease, extracapsular extension, more than 1 node, or if it is more than 20 millimeter, or 3 nodes, regardless extracapsular extension. And non-nodal, intransit metastasis, perineal invasion, T4 lesion, and recurrent CSCC, that is cutaneous squamous cell carcinoma. What was the eligibility? That is macroscopic gross resection of all pathologically confirmed CSCC disease, completion of post-operative radiation, and ECOG was 0 to 1, adequate hepatic, renal, and bone marrow function. And exclusion was SCC arising from non-cutaneous sites, concurrent malignancy, hematological malignancy, less CLL, and history of solid organ transplant, less corneal transplantation. Now, methods and endpoints. Endpoints primary was disease-free survival. Secondary endpoints was freedom from locoregional recurrence, freedom from distant recurrence, cumulative occurrence of second primary CSCC tumor, overall survival, and safety. And statistical consideration, power and sample size calculated. Hazard ratio was 0.6 with 3 years DFS of 55% in the placebo arm, and enrollment was 412 patients, 165 events required to provide 90% power. Now, patient disposition, that is 415 randomized, 209 allocated to cemiplimab, 205 received treatment, 206 allocated placebo, 204 received treatment. That is placebo. And here we see demographic issues, that is mostly 70 years patients, male sex was predominant, whites are more, and we see here Australia, New Zealand, and North America population was more, and rest of the world it is 39%. Head neck cases was more, and high risk factors, nodal was 60%, non-nodal 40%. Again, nodal disease, high risk factor, extracapsular extension, and more than one lymph node, more than 20 millimeter. In this graph, we see that disease-free survival, it is hazard ratio was 0.319, and p-value was significant, 0.0001, and median overall survival placebo 49.4, and for cemiplimab it is not reached. Regarding this disease-free survival according to pre-specified subgroups, that is cemiplimab was better and placebo group was not that much better. Now, disease-free survival by dosing regimen, we see here 3 weekly dosing and 3 weekly followed by 6 weekly dosing. Here, the 3 weekly followed by 6 weekly dosing was better in comparison to 3 weekly only. And 12 months, there was estimated probability of DFS 89%, and after 3 weekly followed by 6 weekly, it was 93%, and 24 months 84%, and followed by it is 88%. And here we see that freedom-free locoregional recurrence and freedom-free distal recurrence both are significant in case of semiplevab rather than placebo. Here one thing we must inform here that grade 3 immunotherapy induced side effects were very less comparison to placebo, and most of them suffered from fatigue, pruritus, rash, diarrhea, and arthralgia, and hypothyroidism. Now, regarding conclusion of this study, semiplevab is the only systemic therapy to demonstrate a significant and clinically meaningful reduction in disease recurrence and adjuvant therapy for patients with high risk cutaneous squamous carcinoma. Semiplevab improves freedom from both locoregional and distance recurrence with 80% and 65% reduction versus placebo respectively. The safety profile of semiplevab for high risk cutaneous squamous carcinoma in the adjuvant setting is consistent with the profile in the advanced metastatic CSCC setting and overall semiplevab profile. Similar efficacy and safety were observed with both regimen, that is 3 weekly and 3 weekly followed by 6 weekly. Adjuvant semiplevab represents a potential new standard of care in patients at high risk cutaneous squamous cell carcinoma recurrence. Thank you very much for patient sharing.
Thank you, Dr. Kudrati Ilahi, sir. Now the floor is open for question and answer session. So, do we have any questions from the audience? So, Dr. Russell?
Thank you, all the presenter, for nice presentation. My question is regarding keynote 689, Dr. Masudul Hasan Orub sir. How will we decide the operative area or radiation field in case of PCR in Pembram? In this study, there is about 10 patient PCR.
Okay, actually, the site of operation or radiotherapy, it will come from the pre-treatment imaging, pre-treatment clinical findings. Say some of the patients who showed the complete response after pembrolizumab, though the number is not that much, but after completion of neoadjuvant treatment, we have to look for the previous documentation of CT scan, MRI, PET CT scan, and also the clinical findings. During clinical examination, what were the clinical findings, which lymph nodes were involved, which lymph node had metastasis before and after surgery. So I think the documentation, it will help to guide us to where the operation will be done. And at the same time, the radiotherapy things, it will come in the same way, because we'll have all the documents, and when we give radiotherapy, we give a region, not only the disease part. We give a nodal basin, we irradiate a nodal basin, including the primary site. So there is no chance of leaving some of the tumors or some of the disease part behind.
Thank you, sir.
Thank you, Dr. Orub, for your elaborate explanation. Any other question from the audience?
thank you for nice talks. I am Dr. Mansoor, working in Dawam Hospital in UAE. My question from Dr. Asma regarding concomitant chemoradiotherapy in cervical cancer. So when you are giving this medication, so how it is helping you in radiotherapy planning? Because many times the cervical tumor is very big, and then how have you seen it shrinking better? And what is your cut-off line for the locally advanced? Means from what stage you are giving this concomitant?
Great question. Thank you, sir. If you repeat this question again, it was not so clear.
In cervical cancers, high-risk cervical cancer, you are giving this new medication concurrent with chemoradiotherapy. So what is your cut-off line? How you are selecting the patients? Which high-risk patients you are selecting? And then during radiotherapy planning, when you are giving external beam and then going to brachytherapy, are you seeing good response, that tumor shrinking faster or much smaller as compared to standard treatment?
Thank you. First of all, selection. Selection was done in this study according to FIGO stage for 2014, stage 1B to 2B, node positive disease, and stage 3 and 4A disease. These are the high risk population, as because there is node the study shows there's 89% patients had node positive disease. And regarding the radiotherapy technique, all patients received VMAT and IMRT. And brachytherapy was 3D brachytherapy. And of course, there is shrinkage of tumor after giving concurrent chemoradiotherapy along with immunotherapy.
So this was included in the inclusion criteria. Thank you, doctor. So we are running out of time because in the next session we will be having online speakers. So we'll be going for comments from the panel of experts. First of all, Dr. Vijay Kumar Srinivasalu, we would like to have your thoughts on the phase 3 trial on adjuvant cemiplimab.
Thank you. Thank you for a very good presentation from all presenter. My question, or rather comment, goes to Professor Asma. From what you have presented, how can you convince us that there is truly a role of pembrolizumab in this population? Because, you know, if you look at the standard treatment which exists, the normal chemorad for cervical cancer, stage 1, stage 2, the cure rates are almost the same from what you have presented. And if you look at the time of the study, the first randomization in June 2020, and then in June, and then in 2022, it's roughly 3 to 4, 5 years. So how can you be sure that what you have seen is not actually what you would have seen in standard treatment that we are giving right now? But otherwise, it's a very good presentation, because we need to investigate this cervical cancer, which is potentially preventable and curable as well. And number 2 goes to Brigadier General. Thank you for the very good presentation with the statistically very significant difference between the placebo and the cemiplimab as squamous cell carcinoma. What's your comment on comparing the cemiplimab with the standard treatment now, so that we can know which one is superior, because you have just compared it with the placebo? Thank you.
Thank you for your nice question. Regarding cemiplimab and placebo, our standard of treatment is now, after high risk cases, we are going for surgery and radiotherapy. As